Okay, so next we have Dr. Edmond, Dr. Jane Edmond. She's the inaugural chair and professor at the Department of Ophthalmology, Dell Medical School, and director of the Mitchel and Shannon Wong Institute. But most importantly, she sits on our scientific advisory board for the NR2F1 Foundation. I first met Dr. Edmond, and many of you who were at the 2018 conference also met with her. She provided, and Dr. Shaw. She and Dr. Shaw provided one-on-one eye exams for all of our kids. And I have to say that was probably the most thorough and best ophthalmology exam my daughter has ever had since. So we're very grateful for that. But that's when a lot of us first met Dr. Edmond. And since those exams, she has been on board and part of the team for NR2F1 Foundation and very dedicated to our kids. Are we ready for Dr. Edmond?
Hi, everybody. Thank you so much, Carly, for inviting me. And thank you very much to Dr. Shaw for involving me in this, the Family Conference of 2018 and being patient with the development of the paper that should be ready and packaged up by the end of this week to submit to a genetics journal about our findings from the exams that we undertook in 2018. So I really appreciate being here. Dr. Shaw had a beautiful picture of the city of Heidelberg. I have a photograph of Austin, Texas at the very end. And my university was founded only 500 years after his, so he's got me beat out. 1888 for the University of Texas. So I was at Baylor College of Medicine and Texas Children's Hospital, a great place to practice and learn and be an academic ophthalmologist and neuro-ophthalmologist at the time of the family meeting, and since have taken this new position. So I'll get kicked off. Let's see. I am trying to advance the slides. Down here. Okay, very good. So I wanted to give a little bit of an overview for the families about the visual pathway, and then specifically discussing optic atrophy, optic nerve hypoplasia, and brain-based vision processing, which is the cortical vision impairment that Dr. Shaw has discussed and that you all know about. So the visual pathway, light and images fall in the retina, which is a layer of the eye with vision cells that carry axons or the extensions of the vision cells to the brain through the optic nerve. So the retina sends out 1 million neural connections, which create the optic nerve. This is the head of, as we look inside the eye through the dilated pupil, we see an optic nerve, and that is imaged right here. And behind that optic nerve head is a very long optic nerve that crosses inside the brain. It's called a decussation, and then flows through to the back of the brain. There's a synapse here where that long axon or nerve tail ends, and then another neural system begins, and that connects to the back of the brain, the occipital lobe, and some other parts of the brain I'll discuss in a moment. So we have, 1 million nerves create the optic nerve. And the optic nerve, as I indicated, travels through the eye socket, exits, and connects with the brain. All 4 lobes of the brain are involved with vision and vision processing and eye movement. It is said that 65% of our brains are involved with vision or ocular movement. So the visual pathway basically is comprised of the retina, the optic nerve, and the brain. So 3 basic parts to the visual pathway. Damage or abnormalities to any of these parts can lead to vision abnormalities. And decreased vision or decreased peripheral vision. NR2F1 mutations lead to we do not know of any retina abnormalities. We know about the optic nerve abnormalities, which within that category are atrophy, and I'll discuss that, and hypoplasia. And then the brain-based vision abnormalities, which depending on what country you live in, it is called cortical vision impairment or cerebral vision impairment. Cerebral, and this is what Dr. Shah will be discussing after me, is probably the most appropriate term for brain-based vision impairment. But again, it just, we're going to, from here out, call it CVI and different nomenclature depending on where you live. So what is optic atrophy? A very common feature, as you know, in this syndrome. Optic atrophy means degenerated or deteriorated. How do we diagnose optic atrophy? Well, here's a picture of a healthy optic nerve. These two are healthy. They are pink or palish pink, depending on the complexion of the individual. So we diagnose as ophthalmologists optic atrophy by seeing a pale optic nerve on an eye exam, dilated eye exam, or on a photograph. We also can diagnose more quantitatively optic atrophy by doing diagnostic studies, which are performed in the office. Another way to diagnose more quantitatively diagnose optic atrophy is by finding thinning of the nerves that comprise the optic nerve, as documented by this in-office test called ocular coherence tomography, or OCT for short. And there are a lot of types of OCT, and most specifically, what I'm talking about is retinal nerve fiber layer OCT, RNFL OCT. You see the printout of the test right here, and this is from one of our actual patients from that study day. So what does optic atrophy lead to? What does it cause? Well, it can cause decreased visual acuity, and most of the time in our patients, that was the most obvious effect of the optic atrophy. It can also lead to nystagmus. If optic nerves are atrophic enough, nystagmus will develop. And it also may lead to abnormal peripheral vision. So you can think of vision in two parts: central vision, which is the part of our retina and brain that we use to read the letters off the chart. Our central vision is what we're using in that test. Peripheral vision is our side vision. And those nerves that make up the optic nerve also provide us with our peripheral vision, central and peripheral. So optic atrophy, again, can lead to decreased visual acuity, nystagmus, and abnormal peripheral vision. The peripheral vision was the hardest test to perform on your kids, because it takes a lot of cooperation to do a quantitative exam of peripheral vision. It's hard enough to do it counting fingers in the office, but to do a quantitative exam like this with machines, it was even, we were unable to do it in any child. It's hard enough for me to take that test. So it's a difficult test to cooperate for. So what is optic nerve hypoplasia? Hypoplasia means smaller than normal size, underdeveloped. So the optic nerve probably doesn't contain the normal 1,000,000 optic nerves, or maybe those optic nerves, there are 1,000,000, but they're just shriveled up from the atrophy. So optic nerve hypoplasia means an optic nerve head that you see like you see in this photo. This is from one of our patients from that study day. This optic nerve head is slightly smaller than normal. So this is what we found on many of your patients, and I have the data on that. So often the hypoplasia we found, it was the optic nerves were also pale or atrophic. So the atrophy was the predominant finding, and hypoplasia, or a smallish optic nerve head, was a bit less common, but was concurrent with optic atrophy. And it is likely that the optic nerve hypoplasia in our kids, in the NR2F1 kids, is due to interruption of normal growth of the optic nerve early in life. So if you Google or put into a search engine optic nerve hypoplasia, you will find 99% of the hits will be about a spectrum of optic nerve hypoplasia that also has central brain abnormalities, such as pituitary axis abnormalities, pituitary abnormalities on MRI. These are not our patients. This is not the BBSOAS patients. So don't be lured into the researching optic nerve hypoplasia as it stands in the literature. Hypoplasia, we should really be renaming that spectrum of disorders with the pituitary and hypothalamic axis abnormalities. It is separate from what we were seeing in our kids. And it is my hypothesis that the slightly small optic nerve head was due to the atrophy and interruption of normal growth early in life. So how do we diagnose the optic nerve hypoplasia, which I'll be showing you the results of that study day. We diagnosed it just like we diagnosed optic atrophy, a smallish optic nerve on the eye exam, or when we were able on photograph like we have here. It was difficult to obtain photographs on every patient because if patients have not normal visual acuity, it is difficult to fixate on the little spot, look at the center of the screen so that we can obtain the image like this. If the visual acuity is not good enough, it's difficult to do that. If there's developmental delay, it's difficult to understand the test. And if you were very young, that compounded it. So we did not have photographs on every patient. So sometimes we just had to use our own eyes, looking inside of the your family's eyes with the microscope we wear on our heads. We can also diagnose optic nerve hypoplasia by, again, OCT. Again, we were unable to obtain that test on all patients because of the difficulty to cooperate, may be due to vision or development. Optic nerve hypoplasia, just like optic atrophy, can lead to decreased visual acuity, nystagmus, and abnormal peripheral vision. So what is cortical or cerebral vision impairment? Well, that is vision impairment not due to damage to the vision processing areas in the brain. Predominantly, we have 4 lobes of the brain. This is predominantly 3 lobes that are implicated in cortical vision impairment. The primary visual cortex, and I know Dr. Shaw will get into this, is the occipital lobe. It's at the very back. And then visual processing areas where information is sent from the occipital lobe to other lobes of the brain to process and understand what we are seeing. Those are the temporal and parietal lobes. So CVI may or may not lead to decreased visual acuity. It may or may not lead to abnormal visual fields, and it typically has been taught to us that it does not lead to nystagmus. It often, now, when I was growing up in ophthalmology, and I finished my training in 1990, and I was taught at that time that cortical vision impairment did not cause optic nerve abnormalities. That it was segregated to the back of the brain, and if you saw a normal optic nerve on exam, but the child had abnormal visual function and a history of, say, prematurity or injury or an event to the back of the brain or the brain, and that's how we made the diagnosis of CVI. But now that we have this diagnostic imaging, like I've shown you with the OCT, and we've gotten better, and we can use photographs to study the optic nerve, because can be difficult to look at an optic nerve in a young child with poor vision, whose eye is moving around 200 miles an hour. And this, Dr. Schaff indicated that the average diagnosis of the optic atrophy was at 5 years of age. It is often, I would imagine, it is likely due to the difficulty of seeing the optic nerve moving, in an uncooperative, non-cooperative, or less cooperative patient. And we're using the indirect ophthalmoscope as the microscope that we wear on our heads with the lens. That's difficult to study the optic nerve in that situation. So the diagnostic imaging equipment that we now increasingly have in our pediatric ophthalmology practices, it's been in adult practices for decades, but pediatric ophthalmologists have been very slow to adopt that technology and understand it. Now that we're academic ophthalmology practices, pediatric, are all have this diagnostic imaging equipment now, we're now seeing that children with brain-based insults, they all have optic atrophy. It's typically mild, but there is a communication between the back of the brain and the front of the posterior visual pathways and the anterior visual pathways, so that there is an effect to the optic nerve in children that have posterior visual pathway insults. And atrophy, an atrophic nerve, can appear as a small optic nerve head, usually mild, just like we've seen in our patients. So what are the vision abnormalities, common visual behaviors reported in the literature for CVI? There are questionnaires and charts that have probably up to 50 common visual behaviors. I pulled off about the top 5 that I feel are the top 5. Difficulty recognizing objects and faces, and Dr. Shaw will, I'm sure, discuss this more eloquently or extensively. Difficult with route finding or wayfinding, delays in visual attention or recognizing objects, needs for objects to be moving, but to see them, but not too fast, and then inability to find an object in a cluttered field. CVI is difficult to diagnose. Currently, there is a lack of a standard protocol or diagnostic criteria that is agreed upon by the national, international community for assessing and diagnosing childhood CVI. Ophthalmologists typically, and this is based on a paper I just pulled, which resonated with my experience, ophthalmologists typically diagnose CVI based on visual difficulties which are unexplained by the eye exam, which means no marked nystagmus, no significant optic atrophy, and it is often a diagnosis of exclusion. Poor visual attention, poor visual behavior, poor visual acuity that is not explained by findings in the eye exam, like significant optic atrophy, plus a history of other neurologic impairments that go along with the posterior visual pathway abnormality. Typically, cortical vision impairment does not occur in isolation. It is part of the, CVI comes from 3 parts of the brain. So there are other neurologic findings in these patients as well. And often the history of an abnormal brain MRI is helping us to confirm the diagnosis. What about using these structured history taking and questionnaires with up to 50 questions? They should never be used in isolation. They must be supplemented by the history and exam. And these have yet, as I've indicated, to be validated and approved by a national community of experts. So what did we, I was happily part of the BBSOAS Family Conference in 2018 at Texas Children's Hospital. Dr. Shaw invited me and Dr. Shaw 27 participants, and from here on, I'll present the results of that conference, which we will publish. 27 participants were enrolled in the conference, and one individual did not receive a complete eye exam. 26 individuals received an eye exam on which I will report. So the findings of this patient cohort or individuals, the ages were from 2 to 37 years of age, 11 males, 15 females. And the mutations that you see here, Dr. Schaff, I really, really appreciate the explanations Dr. Schaff provided about the gene function and the binding domains and how what testing is ordered, what chromosomal testing. I took notes because I am not a geneticist. I'm a pediatric neuro-ophthalmologist, so I really appreciated his very clear, concise explanations. So in this patient group, we had 10 patients with a DNA binding domain mutation, 3 with a ligand binding domain mutation, and we lumped the 13 other individuals into another group. Translation initiation site 5, mutation outside of DBD and LBD, 3 of those individuals, and deletions of the entire gene in 5. And so here is our findings, and this will be a graph that's in the paper, and I've defined the finding, which is the phenotype, developmental delay, et cetera. So you have already heard from Dr. Schaff about the top phenotypic findings. Hypo or alacrima, that was reported in the paper of Dr. Schaff and our group published a few years ago. That is one of the very predominant findings in these individuals. Reduced reflex or emotional tears. So if we are injured, we cry emotional tears. We're sad, we cry emotional tears. If we get something in our eye, we cry reflex tears. So we found, as has been reported, a very large percentage of patients had reduced reflex or emotional tears. Decreased visual acuity in 23 out of 26. Eye shaking, nystagmus, I'll discuss that, 17 out of 26. CVI, this was predominantly based on a questionnaire, which 17 families completed, so 11 out of 17. Optic atrophy in 24 of 26. A small optic nerve head, 14 of 26. And a new finding that we will be reporting, atypical folds of the brain in the temporal lobe. Dysgyria, I'll talk about that in a moment, a very common finding in the 19 MRIs we were sent. 18 patients, individuals had dysgyria, and we'll talk about all of these things. So decreased visual acuity, 88% were found to have abnormal visual acuity. The average visual acuity was 2100. So I know a lot of folks on this call are from Europe, and vision is assessed in a different way. We use Snellen, which is the 20/20, 2100, et cetera. But the normal, if we're using Snellen criteria, is 20/20. So you can see that 2100 is significantly reduced from normal. That was the average visual acuity. Abnormal, decreased, or absent emotional or reflex tears found in 77%. Nystagmus, which was either resolved. Many children had a history of nystagmus earlier in life that had resolved. So resolved nystagmus or nystagmus present with both eyes open or with one eye covered. We found that in 65% of patients. Optic, what did we find on a dilate exam when we looked at the optic nerve? Only 2 individuals had a normal appearing optic nerve. That's 8%. These two individuals, because they had normal visual acuity, were able to cooperate for a more complete eye exam. They were able to perform color vision, which was normal. Color vision is an indicator of optic nerve health. And they had a normal OCT as well. So a very normal complement of nerve fibers comprising the optic nerve. The optic nerve was abnormal in 24 out of the 26, 92%. And it ranged from mild to moderate atrophy, with 2 individuals appearing to have severe optic atrophy. Concurrent with this was mild reduction in the optic nerve head size in 14 out of the 24. 58% of those with optic atrophy also had a reduced size of the optic nerve head or hypoplasia. Only one individual in this group had normal visual acuity. And I have the remaining, I have to move the box here. I can't see the bottom part of my slide, but the remaining had reduced visual acuity. So what about CVI? How many of this family, the individuals that attended the family conference had CVI? Well, as I've indicated, it was difficult to diagnose because, especially given the high prevalence of optic nerve abnormalities. As I told you in the previous slide, CVI is typically a diagnosis of exclusion because the optic nerve is normal appearing or mildly atrophic. And most of our kids had significant optic nerve atrophy plus the hypoplasia. So that made it difficult to diagnose CVI. So after the conference, we sent out a questionnaire. At the time, we provided the questionnaire to the families. We asked the whole group, but 17 families responded about 2 CVI behaviors. And at the time, there was even less information, less published questionnaires about CVI to pull those questions to ask our families. So of the 2, we provided 2 questions: difficulty handling complex scenes, which is called crowding, and delayed responses when looking at objects, visual latency. And 11 of the 17 families who responded yes to both questions. That's 65%, which implies an element of CVI. But I have even stronger evidence that there is an element of CVI based on a brand new MRI finding. So did the visual acuities correlate with optic atrophy in our patients with or without a small optic nerve head? In other words, did more severe optic nerve abnormalities, which we saw on our exam or were able to document with the OCT and photographs, did that associate with worse vision? And on the flip side, did mild optic nerve abnormalities associate with better vision? Not really. We found that optic nerve abnormalities could be mild and associated with poor visual acuity, or moderate and associated with good vision. And this helps us also imply that there is cortical vision impairment, especially in this group, mild optic nerve abnormalities associated with poor vision. So why would this be? As I just alluded to, there's several possible reasons. Our visual assessment of the color and size of the optic nerve is prone to error. As I indicated before, it is hard to study the optic nerve, and I think that's why the average age of diagnosis of optic atrophy in our kids is 5 years of age, because it is hard to study the color and size of the optic nerve with the binocular indirect ophthalmoscopy, the microscope we wear on our heads. OCT is much more reliable, but it's difficult to cooperate for that testing, especially if your visual acuity is not normal. And if you have nystagmus, it makes it almost impossible. So another reason is the severity of optic nerve abnormality doesn't always correlate with decreased visual acuity. We saw that in one patient who had moderate optic atrophy, no photograph, but documented to have moderate paleness. Individual had normal vision, normal visual acuity, but likely had very abnormal visual fields. Another optic nerves support central vision and peripheral vision. Visual acuity is central vision. That's what the only test of visual function we could perform. This individual probably had very abnormal peripheral vision. And then the last possible reason is an overlay of cortical vision impairment. It very likely was the cause of decreased visual acuity when the optic nerve abnormality appeared to be mild, but the vision was poor. So what about the MRI findings? This is very exciting. 19 families provided brain MRIs that had most of them had been performed at the outside hospitals, but sent in to be interpreted by our TCH pediatric neuroradiology team. And what was noted was mesial or medial temporal lobe dysgyria. What is that? That is an gyri are the outer bumps on the brain. This is a gyrus, the bump on the brain. This is a sulcus, which is the dip or the crevice here. So what was noted was dysgyria, or an abnormal shape of the outer bumps in one particular region, and that was in one particular region of the temporal lobe, mesial or medial or internal temporal lobe. In general, though, dysgyria is noted in many genetic causes of abnormal brain development. So in our BBSOAS patients that provided their MRIs, 19, in 18, mesial or medial temporal lobe dysgyria was noted in 94%. All 18 had optic atrophy and decreased visual acuity. So how is the mesial or medial temporal lobe, what does that part of the brain do? Well, and Dr. Shaw, I'm sure will discuss this, the temporal lobe is involved in visual processing, like the parietal lobe, but it is sort of the second pathway of visual processing called the what pathway. Here is the the parietal pathway. Here is the temporal pathway. It's also called the ventral stream. Information from the visual information from the occipital lobe goes to the temporal lobe to get processed, and it is sort of the where pathway. It allows us to perceive and recognize shapes, orientation, size, objects, faces, and text. It's important in visual memory as well. And abnormal development of the temporal lobe is associated with CVI and many other studies. So this highly implicates CVI to be present in the BBSOAS kids, in addition to the optic nerve findings. So here's what it looks like. This is the mesial temporal lobe right here. This is medial. And this is the normal MRI revealing the gyri and the sulci here. You can see the indentations, and here's a gyrus, here's a sulcus. This is the normal appearance. And this was an image provided to us by the neuroradiologist of the finding that was noted in the BBSOAS kids. And here is, with the stars, the mesial temporal lobe, which appears to me to be more smooth. So this is dysgyria that was noted in 18 of the 19 images MRI sent. So, I think I went backwards. I've already covered that. Sorry. So in conclusion, we found reduced visual acuity in 88% of those who attended the meeting. The average visual acuity was 2100 in Snellen nomenclature, and that is logMAR, which is the way we report it, is 0.71. Optic atrophy was noted in 92% of our family conference patients, and 58% displayed a mild reduction in the size of the optic nerve head, none with severe reduction, optic nerve hypoplasia. Nystagmus either resolved or present on exam with both eyes open or uncovering an eye was present in 65%. The lacrimation abnormality is 77%. And to do the genotype-phenotype correlation, poor visual acuity, presence of a nystagmus, and optic nerve abnormalities were the highest in the DBD mutation group, intermediate in the other group, and the lowest in the LBD mutation group. And two of them, individuals in that group, had normal optic nerves and vision. There was, as I indicated before, there's a lack of correlation between the degree of optic nerve abnormality and on dilated exam and the visual acuity. Overlay of CVI, based on our few survey questions, 65% of the participants in the study appeared to have CVI, but it, as I indicated, confounded by the high percentage of optic nerve abnormalities in the study group. But more convincing evidence for CVI was the lack of correlation of visual acuity, poor visual acuity with apparently better optic nerve health, and especially the last, the mesial or medial temporal lobe dysgyria, which was present on 94% of those who sent in MRI scans. And we know that the temporal lobe is very involved in vision processing. So there we go. I think I'm done. Pause share. I'll stop my share.
How about that?
Good.
Thank you, Dr. Edmond, so much. That was wonderful. And I think it's really interesting to hear your findings with regard to CVI, because you mentioned it is very difficult to get a diagnosis since there really is no standard for an exam.
And it's so easy, Carly, to blame the visual abnormalities on the optic nerve. And so
Right.
I have, because we feel there's a combination of anterior visual pathway, optic nerve based vision impairment, and posterior visual pathway vision impairment, or CVI. Why is that important? So I've had to deconstruct this for your families and for so many other patients I care for with genetic causes of vision impairment and neurologic impairment. Why is it even important? Well, if you talk to teachers for the visually impaired, ocular vision loss, students with ocular vision loss, optic nerve based or retina based loss of vision versus brain based, you educate them in a much different way. So that's why it's, I think, important for us to help your families on the state eye report, or for early childhood intervention, or for education, that there is highly likely an overlay of CVI in addition to the optic nerve abnormalities, to help guide teachers for the visually impaired, who apparently have a pretty bifurcated pathway on how they educate these kids, at least in Texas. And we have one of the premier schools for the blind and visually impaired here. And I work with their teachers for the visually impaired. So this is what I have been told. I wanted to make one additional point based on what Dr. Schaaf had reported about vision over time, that the families have reported that I think I documented a quarter or a significant percentage of over time, the vision appears to be getting worse, but a larger percentage, the vision got better.
Right.
So optic atrophy never gets better. There are no workarounds. There's no neuroplasticity that we know about. So a patient with optic atrophy at birth, that's going to be a stable, non-progressive vision impairment. But cortical vision impairment, those kids, my experience has mainly been in caring for preterm infants that have had hypoxic ischemic injury that's caused their cerebral palsy, caused their decreased visual acuity, and a little bit of optic atrophy. They get better because brains are neuroplastic. So that's possibly the reason for improvement is the neuroplasticity and the, I almost get 99%, 95% of kids with CVI, strictly CVI, their vision's going to get better. And it'll happen over the first 5 years of life. Then I think that those neuroplastic channels, and Dr. Shaw can speak to this more. I think that neuroplasticity decreases, or the brain workarounds. But yeah, if it's mainly CVI, your kid's going to get better. So maybe that's the reason for the improvements that have been noted in your families.
Right. Yeah, 100%. And I think it's great to have somebody like you on our team to provide this research that backs up our stories as parents anecdotally. You know, when we go and we talk to our teachers and other professionals that work with our kids, we can tell them what we see every day and how they operate on a daily basis. And now we have the research and the science to back that up, you know. So as a parent, that is extremely helpful to sort of validate, you know, where we're coming from. So thank you so much again, Dr. Edmond. I think we will take 1 or 2 questions at this point live because we are really running out of time, and I'm a stickler
I'm sorry
for
to go
schedules.
over. I'm happy to answer some in the chat as well.
Okay.
Or be available later today. I carved out the day. I'm sorry I'm not with you. I carved out the day to hang out with you guys.
Oh, great. Okay, so if anybody has any pressing questions here in the audience right now, go ahead, forever hold your peace. I will say what we will do for questions, don't worry, they won't go unanswered. We'll, again, like everyone else, we'll address those later on and get those to Dr. Edmond and Dr. Schaff. And also I wanted to make note for questions that people have about recordings, will they be able to watch this later? Yes, indeed, we are. We have our wonderful AV team over here that will make a beautiful little video of this entire day of the presentations that we will share with the entire community. So, any questions that we have in the audience before we move to any questions on chat? I think we'll do 1 or 2 questions. Okay.
I have a question in regards to, do you have any tips or tricks to help during those assessments from your perspective?
Okay, can I just jump in real quick with that? We had a question about any tips or tricks to help with the ophthalmology exams, and thank you for that friendly reminder, because I did want to tell everybody to remind you once again, if you go to our website, nr2f1.org, and you go to Family Resources, we have 2 very important letters that you can bring with you to doctors' examinations. We have a letter from Dr. Edmond. It's an open letter to all ophthalmologists as far as what to look for and exams to provide, and a little bit of the history of the findings, of the visual findings. Extremely helpful. I've taken it before, and ophthalmologists are just blown away and so grateful that they have that. So please use that. We also have a letter from Dr. Schaff as well, an open letter, you know, about what therapies and what exams to perform as well regarding BBSOAS. So I hope that answered your question. It's all there. Did you want to add anything to that? Dr. Edmond?
You know what, Carly? I haven't. I'd love to look at that again. I think I did that maybe 1.5 years ago. So maybe
Okay.
I can make it stronger based on what
Sure.
the families need, and very succinct, like write this on the state eye report, or your
Wonderful. Yeah.
or, assistants and aides at school. So yeah, let me look at that again.
Okay. We'll be in touch. Brian, do we have any pressing questions on chat?
We do. From Cecilia, my son only has optic pale nerves. How can this affect the vision?
So pale optic nerves will very likely, they're going to affect one of 2 things: central vision, how well you see looking straight ahead, or the peripheral vision. So what we found though, we were unable to test peripheral vision in the family group, but what we found was 88% of patients had poor center vision. How will they read the chart at the end of the room? So not normal straight ahead vision would be the result of optic atrophy, which is a pale optic nerve. Atrophy and pale go together. So if you hear pale, it is atrophy.
All right, we'll go ahead and wrap this up. Let's give a huge round of applause again for Dr. Edmond. Thank you.
Thank you.